Welcome indeed to this, our second broadcast today. And this is going to be an interview with, again, a former colleague of mine, currently in the UK. And I'm joined by Linzie Priestnall. And Linzie is a Macmillan speech therapist. And she specializes in work with patients who've been affected by experiencing head and neck and oral malignancies. So I'm especially grateful for Linzie's time today. So thank you very much indeed, Linzie, for being with us and taking time to share with you some of your thoughts about what you pretty much experience on a very regular sort of day-to-day basis inside the NHS. So without further ado, maybe let's kick off with some general. Whereabouts are you working, and what is your role in supporting patients with head and neck disease?
So I work at Russell's Hall Hospital in Dudley, and I've been in this particular job for about 16 years. It is a Macmillan post, and it's to look after and support patients going through, as you say, any type of head and neck cancer, whether it's to do with oral cancer, throat cancer, whether they are having radiotherapy, chemotherapy, surgery, possibly all of the above. For those patients who aren't going to be having any treatment through choice or because it's not appropriate for them. So sometimes the palliative side of things as well, and best supportive care. Looking at, from a speech therapy point of view, the swallowing, communication and voice, they're the main aspects, but there's a lot of support and reassurance that's required regardless of their problems. I think predominantly for these patients, the swallowing is the main aspect that a lot of them want to focus on. It may be that some patients have got communication disorders from surgery. However, the swallow always seems to be the main priority for them. They want to be able to eat and drink properly and safely, and communication and voice is a sort of second option for them, really. It's not as much of a priority.
Okay. So in terms of your practice, what are the most common questions you get asked by head and neck cancer patients?
It's really difficult because we see them at different phases of their treatment plans and management. So I work closely with the speech therapists at our other hospital in Wolverhampton, where they have their surgery and their treatment. So I see the patients potentially before even diagnosis, at the point of diagnosis, and then normally before and after their treatment.
Okay, so,
and it's really difficult because
so patients may not be treated surgically there, they're treated at different hospitals.
Yeah, they're all treated in Wolverhampton at New Cross. So there's a stage where I share patients often with the speech therapist there, and then I continue their care when they've been discharged from hospital or finished their treatment. So it's really difficult because a lot of it, again, is around swallowing. Many of our patients where we feel there's a necessity will have a prophylactic peg placed, so they will have a feeding tube in before any major surgery or significant chemo or radiotherapy. And a lot of the question is around how is it going to impact on their swallow, when are they going to be able to eat and drink again, and how is that going to be managed. Again, those who've had other types of surgery might be asking about the communication, about their voice. You know, how long will it be until things get better? When is it going to be normal? And that's the really difficult thing, because there isn't a normal for them anymore. Treatment causes quite significant problems, whether it's the swallowing and or means of communication, and it's really difficult when they ask you a lot of questions which they feel there should be an answer to. And in many cases, they're all individual patients. They can have the same cancer, the same surgery or the same treatment and very different outcomes. And it's managing their realistic views on what's going to be happening. So a lot of the questions are around, when can I eat my steak? When can I go to the pub for a pint? And they're really difficult for the patients where their impairments are really quite significant.
I think that was an element of what Kim spoke about earlier, in the sense that there are sort of quite significant lifestyle changes, really, that are unwanted and unwelcome, and not easily navigated by, there's no textbook on these things, I think.
Not at all. And quality of life is such a major part. And I think for other types of cancer, you can see how it will impact in the life, but some of that can be hidden. And I think for head and neck cancer patients in particular, taking away or reducing someone's ability to eat and drink safely and well, and being able to communicate effectively, that's part of your everyday life, and you don't accept it until it's been taken away and realise how important it is and how difficult it is to regain that and rehabilitate that.
On that point, what do you think are the most difficult challenges, I suppose, specific to these patients? What do you think are the sort of most difficult challenges that they face in your experience?
From my point of view, from speech therapy input, I think the swallowing thing is one of the major aspects. I see that more often than I am having to deal with communication or voice changes on a day-to-day basis. And I think it's just really hard for them to understand that things are going to change. And I think being told you've got a type of cancer and this is your treatment and it's all going to happen really quickly, they've got a lot to take on board, and they are told about side effects and potential changes, and sort of told about realistic outcomes. But I've never been in that situation myself, but listening to it happening with patients, you can only imagine that they don't take on what's going to happen afterwards. They just want to find out that they can be treated. And I think it's then dealing with the aftermath of that. And those who've been treated, and whether it's 6 weeks, 6 months, 6 years down the line, they can still have difficulties. And it's them coming to terms with the fact that these problems are lifelong difficulties. So from our point of view, it can be as simple as their taste never fully recovers, or their salivary glands are damaged significantly and they can't produce enough saliva, so they can't swallow the foods they liked before. I mean, it may be that their actual function of the swallow is normal, but because of the impact of taste and lack of saliva, they'll never go back to eating properly. So it's little things like that. It's just managing things further down the line that I think getting over having a diagnosis, getting over having treatment, or again, in some cases, being told that there is no treatment, it's looking at what's going to happen longer term for them. And that's where the likes of myself and Kim have got a lot more input with these patients and act more as an advocate for them. Doing a lot of support, a lot of reassurance, and that's where the psychological well-being comes in, because it's not black and white. And as I said, two people with the same cancer, same treatment, you can have completely different outcomes, and it's how we manage that and how the patients learn to manage that as well and move on with their life, and that's really hard.
Indeed. I remember one of my earliest encounters, I think one of the first head and neck patients that I came across, and he spoke about the swallowing difficulties and the eating problems, and that led to weight loss over the course of time. And interestingly as well, I remember this was in the summertime, and they arrived with a coat on, and I was thinking it's actually because a feature of the aftermath of treatment is often weight loss. People's retaining, sustaining weight to a satisfactory level. It's an issue, and it's not commonly spoke about. But it's it. And then the secondary issue is actually kind of going out and being in public, where there might be changes to the features of your face, of your capacity to eat.
That's a big impact, because I think a lot of our patients going through the likes of chemoradiotherapy alone may look facially okay. It's not impacted on that so much as what's happening internally, and they do struggle. So somebody might look at someone in a restaurant or a cafe and think they look fine, but they're sitting in a corner facing a wall, coughing and spluttering because they want to be out and do something. It could take them an hour and a half to eat a meal, and that could just be a bowl of soup and a bowl of custard or something simple to try and keep their normality of social life there. But such a huge impact because they know people are watching them, and the stigma attached to not being able to manage that. Then you've got the patients, like you say, who have changes to their anatomy because they have had surgery on the mouth and face that is physically visible to people, and it's people's perception and it's ignorance. There's lots of different issues, but the patients themselves, regardless of how much you can be there to support them, it's happening to them, and only they know how they feel about reactions from other people. And it's all very well as professionals us saying, well, you can modify what you eat and you can go to this particular place and you can sit with a relative that you know really well and try and avoid what's happening around about you, but it has a huge impact on their quality of life, and just not socialising the way they did, you know, not going to the pub for a pint with a friend, which is what they've always done, because they're coughing when they drink, or they can't drink anything at all. And again, you forget that that's just part of everyday life, and little things have a massive impact, and that's not the cancer, that's the treatment for cancer. And I think that's the problem. This can take years in some cases.
So what are your thoughts on psychological recovery as opposed to physical recovery? And do you see the role, or a role, for someone like me, a psychologist, being involved in the overall care of a patient, not just through treatment, but maybe beyond? What are your thoughts on that, Lindsay?
Very much so. I think it's very difficult. I know we've had conversations in the past that there's a stigma attached to psychology input. So I think it was yourself that said to me, if nutrition's an issue, they won't have a problem being referred to a dietitian. If it's a physical problem, they'll happily be referred to a physiotherapist. I think saying to somebody, we feel that you need the support from a psychological perspective, the general presumption from patients is that's a negative thing. I don't want to see psychologists. I'm not mad. I'm not, there's nothing wrong with me. Our point of view is you're going through major changes and we can help you to a degree, but this is something else. This is past our professional boundaries. And there's a huge amount, like I say, being told you've got cancer and being treated. It's a very quick process in many terms, and it's the aftermath that takes months and months, if not years, for some patients. And we do have people who come with very extensive cancers who have huge amounts of surgery or treatment, and seem to be there and be very positive minded. And actually, we don't worry about them so much because they come back for a toxicity clinic after the treatment and they're doing really, really well. And it's almost surprising, because you might have had someone with a smaller cancer and less treatment, and psychologically they're in a much worse place. So it's, again, hard to say when to involve people, but more often than not,
it's not by virtue of the amount or size of treatment. It isn't necessarily in and of itself an indication of how somebody may cope psychologically. They're not necessarily related. It's
not at all.
It's how somebody is organized within themselves, and
and you can see that, because if they come to us sort of pre-radiotherapy or pre-operatively and we have that chat with them, and quite often Kim and I see them together, and you can see the way the person's reacting with you or interacting with you, and you can tell that actually things are going to be better for them. And you can tell with the different patient who, as soon as they walk out the room, and we just think this is going to be a real struggle for us with that patient, they're really going to have difficulty psychologically dealing with what's going on. The support mechanism is obviously really important, and then sadly quite a lot of our patients don't necessarily have close family support or friendships nearby, and that makes it even harder for them. So there's lots of difficulties around those areas. But I think, again, from a psychological perspective, we see patients who could be 2 years, 6 years. In my case, I've had someone recently, 32 years post-radiotherapy, who now has significant swallowing problems. We're eating and drinking absolutely fine for years and years. They've been tested to make sure there's nothing else causing the problem, and it's all put down to changes from radiotherapy. And that's the sad thing as well, where years later they think, well, I've managed all this time, and all of a sudden I can't swallow. And some of these patients are having to have pegs fitted because they can no longer swallow safely. So sort of chronic difficulties which don't happen for years. And as people are living longer and being treated with more harsh treatment, we're seeing more difficulties further down the line as well. And that psychologically for those patients is horrendous.
I think it's a real MDT model of care. It's not just on CNS or yourself or myself or even surgery. I think it's all of us trying to advocate, get alongside the patient and helping them mobilize enough to regain as much of normal life for them as is possible, mindful of the fact that the navigation of that journey is an uphill, can be an uphill struggle, really.
Very much so.
We are advocates as much as clinicians in that regard.
Yeah.
So maybe the final two questions. What's the best advice you could give patients, during treatment? And I know it's a big one, but what's the best advice you could give during and after treatment? And is there anything specific that you would like to get across to patients?
I think from the input that I have from the speech therapy side of things for patients, it's very much for them to listen to their body. And I know that sounds a bit cheesy, but actually the impact treatment has on them can be very different for people depending on their age, that, you know, if they're still working, there's lots of different things to consider as to how they're managing things. And so it's listening to their body and knowing if there is a problem to actually ask for help.
Mm-hmm.
We give them lots of advice beforehand. We're there during and after treatments or surgery, and I think it's them knowing the support's there and having good rapport with your speech therapist, your CNS, your dietitians. I think that NDT is really important for them, so that the slightest thing they ask us about, even if they think it's a silly question, because the sooner we can help them and deal with it or reassure them that it's perfectly normal, even if we've told them a million times, it just, if it makes them feel more comfortable, it's much better for them.
I think that's a lovely word, rapport with your team. I think that's a lovely idea. Having rapport with yourselves, I think is essential. You know, I think it's a key idea, because it mitigates the idea that you're actually going through this alone and that nobody understands. So I think that's a really.
And I think that's it. Yeah. I think we often feel that they are alone, and it's just knowing that they can pick up the phone or come and see us, and we can just say it's absolutely fine, it really isn't a problem, and they know that they're comfortable doing that, and we are comfortable doing that for them.
Okay, Lindsay, I think that's probably brings us to a close. Certainly really appreciate what you said and how you shared with us today. And it goes without saying, but I'll say it anyway, but certainly I've always appreciated working with you, and I really appreciate the care and consideration that you give to your patients. I think it's truly vocational stuff. So certainly I'm really thankful that you're certainly in the lives of people who are faced with these enormous challenges, and I know you certainly do your best for them. So thanks ever so much for your time.
Thank you.
And maybe we'll catch up at some point face to face when we're back to normal.
Nice, yeah.
Okay, take care now.
Thank you.